All right. Do you see that all right, Herman?
Yes.
Okay.
Nicely.
Great. All right. So happy to be with you this morning. And the reason this talk is titled Improving Outcomes in Children with Portal Hypertension is that the prognosis for children with portal hypertension is improving. And I hope that we can continuously improve the health and welfare of children in whatever disease they have. My own experience of this began many years ago when I was a pediatric surgery fellow. I was studying to become a pediatric surgeon, and we had a 2-year-old who had had a Kasai procedure for biliary atresia. She came into our emergency room bleeding from what at that point was standard biliostomy. So you would create a diversionary limb of the small bowel that would come to the outside, and this was thought to decrease the rate of infection. And she had formed massive varices around this stoma, and she nearly bled to death from this event. She became very hypotensive. But the remarkable thing that saved her was she had a stoma bag on this biliostomy, and as it filled up with blood, it actually created pressure to stop the bleeding. And so I always remember this case because she was saved by an ostomy bag. But the reason I mention it is most of us who know portal hypertension know it in this way. We have children who have terrible bleeding, and they create enormous management problems, and they are very, very sick at the time that these events occur. So just a schematic of the portal system. I don't know if you can see, but the purple here is the portal that it comes into the central portion of the liver, branching into right and left branches and supplying a nutrient blood flow. About 70% of nutrient blood flow comes through the portal system into the liver. Now, the normal clinical presentation for portal hypertension is rising portal pressure leads to splenomegaly. Then you develop collateral circulation between the portal and the systemic circulation in the esophagus, the stomach, the anal canal, the falciform ligament, the retroperitoneum. And then this becomes clinically manifest as bleeding esophageal varices, ascites, primary peritonitis of the ascites, hepatopulmonary syndrome, poor weight gain, and developmental delay. Now, if you talk about the strict definition of portal hypertension, it is an elevation in portal pressure, and it is the difference between the wedged hepatic venous pressure, which reflects portal pressure, and the free hepatic venous pressure, and it needs to be greater than 5 millimeters of mercury to meet the definition of portal hypertension. However, you don't really see formation of esophageal varices until that pressure gets up around 12 millimeters of mercury difference between what you would say is central venous pressure and the wedged hepatic vein pressure. We normally divide portal hypertension into pre-hepatic, intrahepatic, and post-hepatic. And I'll spend most of the time today talking about pre-hepatic portal hypertension, and I will spend a little bit of time talking about intrahepatic portal hypertension. Intrahepatic portal hypertension is intrinsic liver disease. Now, there was a relatively famous pediatric surgeon in the United States, Peter Altman, very interested in biliary atresia, and also would talk about portal hypertension. I remember at one of his talks, he talked about this being a bad liver with good veins. And so it's a nice way to remember the intrinsic liver disease form of portal hypertension. So if you look at what is the prognosis for children with portal hypertension in chronic liver disease, the degree of synthetic dysfunction very much contributes to the prognosis with first GI bleeding. So if your synthetic function is bad and you have portal hypertensive bleeding, your prognosis is much worse than otherwise. Sinusoidal occlusive syndrome is something that also occurs inside the liver and is a process that is commonly associated with treatment for some malignancy that requires chemotherapy and results in inflammatory lesions in the sinusoidal area. And with that, you get occlusion, poor flow through the portal system, and portal hypertension. This is why defibrotide has been commonly added now to most regimens for bone marrow transplantation. So the conditioning regimen includes this to hopefully avoid the problems with SOS. The post-hepatic forms of this, we think of Budd-Chiari, hepatic vein thrombosis, and this is usually secondary to an underlying myeloproliferative disorder, and most of these patients are young adults. But let's move on then to talk about the pre-hepatic portal hypertension. So the portal vein obstruction is the most common cause of extrahepatic portal hypertension in children. It accounts for about 30% of all the children with bleeding esophageal varices, and their average age at presentation is about 5 years of age. The bleeding can be precipitated by a respiratory illness. Probably coughing causes rupture of esophageal varices that up to that point in time were asymptomatic, and these children will have splenomegaly. This long-standing portal hypertension can cause obstructive jaundice, and circulating levels of natural anticoagulant proteins are commonly decreased. These would be protein C, protein S, and antithrombin 3. However, true thrombophilia, meaning an underlying predisposition to portal vein thrombosis, is relatively rare. The things that are associated with portal vein thrombosis are umbilical vein catheterization, and at least here in the United States, where we have numerous premature births, umbilical vein catheterization is a very common procedure. And if you follow these umbilical vein catheters, they will all develop some degree of thrombus around them. And so this is why this is a relatively common contributor to portal vein obstruction. Umbilical sepsis, omphalitis is also a predisposition. We mentioned thrombophilic disorders being relatively rare, but they do contribute. And the majority of cases, the etiology is really unknown. Recall that many of these events with portal vein thrombosis are relatively silent because of the dual blood supply of the liver. And so it's only been with the advent of ultrasound, Doppler ultrasound, that we have come to recognize that this is a much more common condition than we had previously realized. The diagnostic studies that confirm this are Doppler ultrasound of the liver. Liver biopsy is mandatory because these children will almost universally have a normal liver. If they don't, it's usually the result of them having an intrinsic disease otherwise, and so it's not really in the same category of a pre-hepatic portal vein thrombosis. Now, the troubling thing about the diagnosis and the anatomic landmark of this is that it's not well demonstrated by ultrasound, CT scan with contrast, or MRI, and that the only important step forward for excellent road mapping of the portal venous system is portal venography. Now, there are further aspects of their workup that must be done. They can develop hepatopulmonary syndrome, so pulse oximetry will show that they are desaturated if they are developing that. They, of course, have physical findings with clubbing of their fingers and perhaps some circumoral cyanosis. Cardiac evaluation is necessary to rule out a mixing disorder of the heart, but it also, by using bubble echocardiography, can confirm the diagnosis of hepatopulmonary syndrome. And then you should also recognize that these children, because they don't have adequate nutrient blood flow to the liver, can have abnormalities. I remember one child in particular who had intrinsic liver disease as his cause of portal hypertension. And he could not draw a star symbol. And within days of his liver transplant was able to complete that. So some of this is correctable. Some of it does leave long-term changes in mental function. Now, this slide just demonstrates what you all know about the various kinds of shunts that can be performed for portal hypertension. Of course, remembering that if we're trying to preserve as much nutrient blood flow to the liver as we can, the division of the portal system into a high pressure and a low pressure system, such as the distal splenorenal shunt, creates continuous portal pressure toward the liver and decompresses through the short gastrics, the esophageal varices, by connecting the splenic vein then directly to the renal vein. These other shunts are what would be called central shunts, meaning that they now decompress all of the portal system into the systemic system. And in that sense, they are not selective, and they contribute to removal of blood from nutrient blood from the liver and putting it into the systemic circulation. So they're not favored shunts for children because we want them to have as much nutrient blood flow to their liver as possible. On the right lower is the TIPS procedure. Now, this procedure is not possible in children with portal vein thrombosis, but it is possible in chronic liver disease. However, it's technically difficult in small children. And most of us, if we get to the place where the liver disease is bad enough to cause portal hypertension that's symptomatic in children, we favor liver transplant rather than the TIPS procedure. We have used it as a bridge in older children for getting them stable so they could be transplanted. And then, of course, I want to spend quite a bit of time talking about the mesoportal shunt, which revascularizes the intrahepatic portal system. This is the so-called Rex shunt in the left lower of the picture diagram of these procedures. Now, this is called the Rex shunt because the space of Rex is where the portal end of this interposition graft is attached. But in fact, if you see the portal system there, you see that there might be other targets for bypass, and we'll talk about that in just a bit. So the mesoportal shunt really was developed by John Deville de Goyer, and he did it actually to treat children who had had liver transplants and clotted their portal veins. So this was a rescue procedure that was initially designed to rescue children who had had liver transplants and had clotted portal veins. However, he began to realize that this same application could be made to children with portal vein thrombosis and has actually been a champion for the procedure through many, many years. It restores normal portal blood flow to the liver. It resolves portal hypertension. And because of better hepatic function, it resolves coagulation defects, etc. So the additional benefits of this are that it has no associated encephalopathy, it restores normal growth patterns, and it may be done preemptively prior to onset of more severe complications. When I was in my training and early practice, the teaching was that portal vein thrombosis should be treated by temporary means, I would say esophageal endosclerosis, banding, even drugs to try to lower portal pressure, the use of Enderol, but one would not do a preemptive surgical procedure because it was, first of all, a very big operation, and you tried to manage them as they collateralize their portosystemic collaterals so that they weren't operated until much later in time. Now, the problem being that this approach did not really address the underlying problem, which was that these children were growing up with inadequate portal blood flow, and those were causing abnormalities in their development and their growth. So this is a technically challenging procedure. Most people don't do enough liver work that they feel very comfortable around the liver's portal anatomy, portal system. And because the imaging of this was so inadequate, it left you in a position where even if you felt comfortable around the portal system, you didn't know what you were going to encounter. I remember a rather embarrassing situation in Bangalore, India. I was visiting my dear friend there, Ashley de Cruz, and we did a demonstration procedure of a child with portal vein thrombosis. And we got to the left portal system, and it was very sclerotic and not adequate. And we wound up having to do a mesocaval shunt rather than a portosystemic, a mesoportal shunt, because the anatomy was unfavorable and we couldn't determine that before this operation. So Jean Deville continued his work in this area and then published a very important paper in the Journal of Pediatric Surgery in 2014, in which they had done anatomical studies of 89 children with portal venous obstruction. And he developed a classification system based on these findings that was strongly associated with prognosis with the mesoportal shunt. Now, this is a gas portogram performed at my own institution. You can see the catheter coming in from the top of the screen. This is a balloon catheter, and CO2 is being injected retrograde, and it's filling the portal system. And you can see all of the branches of the portal system. And most importantly, you can see here on sort of the middle of the screen, the space of Rex is open and the connection between both sides is open, so that if you could attach your shunt in this area, you would have the entire liver as outflow for this mesoportal shunt. Now, this in fact represents the cumulative data from the study that Dr. Deville de Goyer had done, and it shows essentially categorized findings of A, B, C, D, and E as he classified them. If you start with E, you can see that the entire intrahepatic portal system has more or less been destroyed by the thrombotic process, and there is no way to revascularize this system. If you look at D, it also has severe injury to the left and the right portal vein branches. For category C, the left side is still open. For category B, the right side is still open. And in category A, the entire intrahepatic portal system is open. And so it would look more like that and not like E in the lower figure. Now, the reason this is important is that his own experience was that all of those in type A were very successful. Only 1 out of 5 in type B was successful. And this is because the left side is very diminutive. And then if you look at type C, he did only 1 of those. He improved his results from 75% patency to 87% by selecting the patients that were the best candidates. Now, the problem is that if you took all of the patients in this report, less than half of them had favorable anatomy. So this means that you're identifying now a group of patients that can be treated, but sadly, you're also identifying a large group that can't be treated. Now, the Bovino Conference on Portal Hypertension recommended then that the mesoportal shunt be the first possible intervention for children with portal vein obstruction, and that you continue temporizing the others for as long as you can. And then in most cases, they would recommend that you then proceed with a selective splenorenal shunt. Now, I want to talk about the history of our own experience with this procedure of portal vein revascularization. Our first patient we treated was in 2005, and this was a typical age at the time, a 9-year-old. We used an internal jugular vein interposition between the left branch of the portal vein and the superior mesenteric vein, and we had a good outcome. This is a CT scan with contrast demonstrating what this shunt looks like after it is placed and after there is recovery. You can see the spleen is much smaller, so the spleen has decreased in size, and you can see the size of this shunt is actually quite large. Now, over the 9 years since 2005 that we operated other children, we found actually late in this experience, we began to run into what I would call reality, which is the odds were against us from the beginning. We had no roadmap to tell us whether the anatomy was favorable. And in one case, we ran into a huge cavernoma in the space of Rex that made it impossible for us to proceed. And in another case, the left portal vein was very hypoplastic. And so we knew that we had a problem with our strategy for this surgical correction. Now, on one of the trips to Santa Cruz to be with my friends, we had a 17-year-old with portal vein thrombosis, and my colleague from Jefferson Medical College, Dr. Warren Maley, was with me, and we were reviewing this. Warren has been the one doing the living donors for us in Bolivia for a number of years now. And we were wondering if there was an application we could make to revascularize the portal system by using a right-sided approach, because we thought we could see some contrast in the right portal vein. And so in a very long procedure and a very long shunt requiring the entire left internal jugular vein, and then an addition of saphenous vein that was spiraled to enlarge the diameter. So a 12-centimeter shunt from the right portal vein to what turned out to be essentially the thrombosed end of the portal vein at the head of the pancreas. We were able to construct a right-sided mesoportal shunt. And this is not that patient, this is a subsequent patient, but you can see what this graft looks like. I apologize for all the very bright areas. Part of this is because this individual has such massive splenomegaly. The interventional radiologist had been here taking down large collaterals to redirect blood flow into the liver, and also subsequently to do some splenic artery embolization. But you can see that a right-sided approach is possible. The anatomy is very different. You're working behind the bile duct. Everything is sort of rolled over. You have huge cavernomas to work around. It is a very challenging operation, but it's possible. Now, the case that really changed our understanding of how we can approach this disease was a child who, at the time of surgery, 8 years old, had had a non-Hodgkin's lymphoma in the head of the pancreas prior, from which he had recovered, but it had caused extrahepatic portal venous obstruction. We did a mesoportal shunt, and we had difficulties with the shunt remaining patent. And so our interventional radiologist, Dr. Debbie Rabinovitz, had been doing multiple studies to try to help us and do thrombectomies. And what happened was really unique. During one of these events, and I was in the observation area down in interventional radiology when it happened, she had percutaneously cannulated the intrahepatic portal system, and she was passing a guide wire down through the right branch of the portal vein, trying to get into the graft so that she could do thrombolysis. And the wire passed into what appeared to be the normal anatomic relationship of the main portal vein and the splenic vein. And I remember at the time I said to her, you know, Debbie, I think that's either a great move or you've just perforated the portal vein. I said, what are you going to do? And she said, I'm going to dilate it. And I thought to myself, okay, there are brave interventional radiologists in addition to surgeons. And she did. And the result was that the portal vein actually opened up. Now I want to show you, I'm going to skip ahead a little bit here to what this actually looks like. So this is a different case. This is a 2-year-old, and you can see in the left-hand box what the portal venous obstruction looks like with large cavernomas. You can see in the central box the gas portography showing the intrahepatic portal system is open. And then in the right box, this is what happens when you are able to get into the native portal system and do balloon dilation and reopen the portal system. Now this is a marvelous advance because we're revascularizing the intrahepatic portal system in a quote unquote non-invasive way. It is very invasive, but it is not this big operation where we take one of the internal jugular veins and we do a bypass. This is something that is possible using interventional radiology. Now I'm going to skip back to some of the slides I had previously put up. So dilation of portal vein thrombosis is becoming much more recognized in the adult world. And at least in one report by Salem et al., they had initially 100% success with this and 92% long-term patency. Now, there had been a case report prior to our report, and then this, the last 2 bullets here are about our own patient and the balloon dilation leading to long-term patency. We then performed in 6 subsequent patients an IRB approved study looking at ages 13 months to 12 years and did this very same procedure. Interestingly enough, in the work done by Jean Deville, he noted that any umbilical vein catheter history was a very poor prognosticator. However, although 5 of these 6 children had had umbilical vein catheters, we had a very high success rate of reopening the portal vein with an interventional approach. Before we do this, we have consultation by a multidisciplinary team. We do cross-sectional imaging and an echocardiogram. As much as anything, we're doing the echocardiogram to try to prevent right to left passage of any material during this extensive interventional procedure. We do normal stuff in terms of screening for laboratory tests. And then in IR, we start with a diagnostic hepatic venogram and an attempt at portal vein recanalization. And we can simultaneously do a superior mesenteric angiogram so that we have, by capturing the venous phase of that imaging and the CO2 imaging of the liver, both the inflow and the outflow diagrams of exactly what's going on with the portal system so that this allows optimal surgical planning. And then I showed you this slide and the demonstration of now the patent portal vein due to interventional radiology only. This is another case. This is actually that original case that I talked about where we had done a previous mesoportal shunt that had thrombosed. And then this was after the salvage procedure. Now, I think it's important to note that this portal vein thrombus or collapse of the portal system had been present for 8 years when it was reopened in this young child. So it is not a lost cause, no matter how long the portal vein has been down. And over time, I think we will probably recognize that certain lengths of time are poor prognosticators. But what we think happens, of course, is that with balloon dilation, there is re-epithelialization of this portal system. Subsequent balloon dilation may be required, and as a result, over time, you will get a very functional portal venous drainage system. All right, I want to transition using Dr. Altman's phrase from good liver, bad veins. We've just been talking about those children, and go to bad livers and good veins. So the most common, I want to focus just briefly on the treatment of biliary atresia. Around the world, these children without transplantation are dying. And they're dying because even with good bile drainage, half of those children will eventually develop biliary cirrhosis, portal hypertension, and have a limited survival opportunity. There are other diseases that are part of the transplant experience. I don't list here acute hepatic failure, which is not a chronic liver disease, but it's certainly an important one, autoimmune hepatitis, cystic fibrosis, all of these others. But the point being that without transplant, the prognosis for these children is grim. Now, I want to go back to something I mentioned earlier, which was the relationship between prognosis and synthetic function. So Ron Sokol, longstanding hepatologist, University of Colorado, published this report many years ago now, in which they looked at a large group of children and their survival after their first portal hypertensive hemorrhage. If they had bad synthetic function, meaning their total bilirubin was greater than 10, half of them were dead at 4 months. If their bilirubin was between 4 and 10, 50% were dead at a year. And if their total bilirubin was less than 4, 20% were dead at 4 years. So the prognosis for these children with synthetic dysfunction is grim, and it gets worse and worse as their synthetic function decreases. The pediatric end-stage liver disease model, or acronym PELD in the United States, was developed from a large database that was kept by the studies of pediatric liver transplantation, and it was based on similar objective parameters that the medical evaluation of liver disease database was. And those variables include age less than 1 year, bilirubin, albumin, INR. These variables are similar to what I was talking about in terms of synthetic function. But I want to show you the relationship between survival and the PELD scores. So this is data from the United States Organ Procurement Network, and it shows how many registrants. This was just a moment in time, but if your PELD was less than 11, your risk of dying is actually quite low. If you have a PELD score greater than 11 up to 18, it increases, and it increases stepwise from there. So the cumulative probability of death is less than 1%. If your PELD is less than 11, it then increases to 3%, 4%, 7%, 8% as your PELD score rises. And you should think of this in one way, in a simple way, as decreasing synthetic function, increasing the risk of death. Now, I want to show you outcomes because the outcomes show you why the prognosis with chronic liver disease is so much worse than the prognosis with liver transplantation, at least in the short term. So those kids who were transplanted less than a PELD score of 11 had a 98% survival, and in 11 to 18, 100%. These numbers reflect relatively short-term survivals. But I would point out to you that your risk of dying without transplant, if your PELD is less than 11, is actually lower than your risk of being transplanted. So we use these numbers not only as a way to tell us when we should transplant, but also as a way to look at children and not to transplant them because the risk of death is so low. So it becomes part of our prognostic evaluation when we're talking about liver transplantation. Now, Let me talk about late outcomes from transplant just for a minute. And I've tried to shorten this talk so that there's time for some questions and it gives more of an overview. Vicky Ng, of course, at Toronto Sick Kids, wonderful hepatologist, looked at this registry through the studies of pediatric liver transplant and 10 years of follow-up and found a lot of things that are of worry to all of us. Comorbidities after transplant, lymphoproliferative disease, renal dysfunction, impaired linear growth, some of which, of course, was present beforehand, and health-related quality of life being normal in only about a third of the patients. A relatively small number had an ideal outcome as defined by being on a single drug, having normal liver function and growth, and having absence of common sequelae. So let me just kind of wrap up some of what we've talked about today. So I think there are improved techniques that restore portal flow in children with normal livers and abnormal veins. It can be done percutaneously. The mesorex shunt is very important, but you can see it's limited by the anatomy. However, mesoportal shunt to the right side increases the number of children that can be treated. It still means that we have a number of children, perhaps 50% of those with portal vein thrombosis who will wind up needing a selective or a non-selective portosystemic shunt. And this is disappointing, but it also is an opportunity for us to continuously improve what we're doing to treat these children and to find a better way. And so part of what I want to leave everyone with, especially for the young people who are in this audience, there is much to be done, and your dedicated work can lead to very significant improvements in the care of these kids. I want to talk about liver transplant around the world. Probably 70+% of the children who need to be transplanted today are dying. And they're dying because they don't have access to transplant care. What we have been trying to do in Bolivia, in India, and Jamaica is to make that more possible by partnering with other sites around the world to help them develop transplant programs. We know that inside of your country, you understand the economics, you understand the medical system. We can come alongside and help people develop this around the world because it will save lives. We want to basically transfer the expertise, the technology possible so that this can happen and be controlled, be under the overall guidance of teams in countries around the world. This is a big hurdle because it is technically a challenging area. Taking an adult liver, taking part of it from a living donor, taking a small part from a brain dead donor. These are important technical procedures that we need to teach others so that they can do them. Lower cost immunosuppressive medications are a key. Our friends in India have gotten the cost of tacrolimus down to about something like 30 cents a milligram. And sometimes I feel that I'm going to be accused in the United States of being an international drug runner because I've been buying tacrolimus in India so that I could ship it to my friends in Bolivia. That didn't work very well, by the way, because as soon as it got to customs, they applied the US valuation of the drug and taxed at that level. It's been a nightmare trying to make this work.
Señora, que le vaya bien.
Now, I would leave you with this thought. The average age at transplant is 3 years. And so the duration of a first liver graft,
Como a veces sale como atronado, él la quería llevar, no sé para
and
qué.
there's a high rate of liver fibrosis. Second transplants will become more common in young adult life. So the challenge is not only to make it possible for kids to be transplanted, but to improve the long-term outcomes for these children. And that's the work that we're trying to do right now with many others around the world. So I thank you for your attention. I'd be glad to answer any questions. And if you...
Hello, Dr. Dunn. Thank you. Thank you very much for your wonderful presentation. We do appreciate. And we have some questions here. Por favor, voy a pedir a la persona que tiene el micrófono abierto a nos haga el favor de apagar su micrófono. Yo he bloqueado acá, pero aparentemente no he conseguido bloquear a todo el mundo. Okay, Dr. Dunn. We have questions here. Dr. Bassan Chenoy, the question is gas photography essential before planning REX shunt, or is it sufficient to have contrast imaging?
Well, I absolutely prefer gas portography. Now, it can be done with contrast. It doesn't have to be gas. Using a balloon catheter, you can use IV contrast, and that's perhaps more readily available. But I think you need to know the anatomy before you do an exploration on these children. If you're going to do something, some people have strategized by saying, well, we'll explore, and if the anatomy is unfavorable, we will do a distal splenorenal shunt as our alternative at that procedure. Now, I would argue that as we develop more expertise, more familiarity, more experience with right-sided mesoportal shunts, the anatomy will tell you when that is possible, and then you can plan that from the beginning. If you decide on the spot that you want to look at the right side, you add many hours of surgery, and it's potentially very, very dangerous because of the big cavernoma around the head of the pancreas and around the common bile duct.
We have another question from Dr. Chenoy also. It is possible to dilate and open up portal vein, or it is branches intraoperatively while you are attempting REX? What is your experience in this regard?
We do the attempted opening of the portal vein preemptively during the initial portal venography, so that at the initial diagnostic imaging, that's when we try the opening of the portal vein. And we only go to REX if that's not possible and the anatomy is favorable.
Dr. Ashad, we see a lot of children with pre-hepatic portal hypertension with massive spleens, with hypersplenism. What is your experience, PO? Do they recover from hypersplenism?
Yes, they do, but we also found that in some cases, because of the length of time and how massive the spleen is, we have to do something to decrease splenic size, like splenic artery embolization, selective in areas to sequentially decrease the size of the spleen. I will mention that the young man that we did the right-sided mesoportal shunt had massive splenomegaly, which completely disappeared within about a 3-month period. So excellent portal decompression will result in these very large spleens getting smaller. Another thing I didn't mention, I should mention, is that initially when you start to revascularize the intrahepatic portal system, the system is relatively hypoplastic and underdeveloped. But over time, it grows and becomes a much more normal looking system, so that if you can keep the shunt flowing in the initial phases, it will increase the capacity for the intrahepatic venous flow.
Okay, we have another. If you don't have expertise in REX shunt, what is your second choice?
Well, I would do a distal splenorenal shunt if possible. And sometimes it's not possible. Sometimes the veins are insufficient, inadequate, and you have to do a shunt. Now, I'm sure some of you all have done splenectomies on a massive splenic enlargement in portal hypertension. That is one of the most difficult operations you will ever do. And so the idea that, well, I'll just take out the spleen and do a splenorenal shunt, it's not that easy. And so I would recommend, if you go down that road, have a companion on your journey who's been there before and has done it. It's a very long, tedious, bloody operation. And frequently it gets abandoned at some point because it's just too difficult.
We have another Dr. Dunn, Dr. Arshad. Criteria for using reg shunt, what age?
The youngest we've done is age 2. And I felt that that had the best outcome because the portal system was very malleable. The liver was soft. It was able to accept a large amount of blood flow, and the portal hypertension resolved very quickly. But again, I'm not sure that I would tackle a 2-year-old. I would do a 2-year-old's operation as the first one I ever did. But I do believe it's an excellent preemptive therapy, and if it's done at a young age, has a very, very good prognosis.
Okay, Dr. Dan, thank you very much for your beautiful presentation. We do appreciate your time, your patience to be with us, and you are so kind all the time. And I will thank you all the people that was linked with us. And we will invite you the next week to see the presentation of Dr. De Badiola. Yes. He's going to present a bladder introduction in neurogenic bladder. So we will waiting for you the next week. Para los que han estado con nosotros, les agradecemos mucho su presencia. Muchas gracias por haber estado presentes y contar con la presencia de ustedes todos los martes hasta el mes de agosto, que vamos a tener diferentes temas. Los interesados, voy a dejar de nuevo el correo en el que pueden comunicarse con nosotros para tener mayor información. We have another question, Dr. Surteche, Dr. Dan.
Yes.
In lack of material for embolization for the larger spleen, have you tried partial splenectomy during the shunt surgery?
We have not. And I must say that those who tackle that operation, I give them great credit. It's a very difficult addition to the operation. It's bloody. It's hard to get the splenic raw surface to stop bleeding with partial splenectomy in one that's massively enlarged.
Okay. Many people are asking here, how do they contact with you, Dr. Dan? May I put your email or your contact?
Yeah, and tell them to be patient with me. I'm the worst at reading email, and you know. So I have a WhatsApp address, and so they're welcome to send me a text, and I'd be glad to contact them on WhatsApp. All right.
Maybe we have another, the last question, please, because we
are sure.
Which protocol of anticoagulant therapy you use after REX procedure? Even the thrombophilia has been ruled out. Yes. The majority of patients have low levels of protein C and S levels.
Right. So we treat them with low molecular weight heparin. If possible, we give them a heparin bolus in the operating room, a small bolus. We measure antithrombin 3 levels, and we replete them if antithrombin 3 levels are low. So we maintain Lovenox, this low molecular weight heparin, for at least 6 weeks to 3 months. We see very little bleeding from this after this procedure. So we think it's safe. Some people have used aspirin. I know that Dr. Superina in Chicago was using Plavix for a while. So I think there are a number of different approaches. I'm not sure it's standardized at this point, but we're using more of a standard approach for post-vascular intervention.
Okay, again, Dr. Dunn, thank you very much for your time, and we will see you soon in Bolivia.
I hope so. Thank you.
Thank you. Thank you, everybody. Vamos a agradecer a todo el mundo por su presencia y los invitamos el próximo martes para estar con nosotros. Un abrazo para todos y hasta el próximo martes.